Welcome everybody. We will discuss the ulcerative, vesicular, and bullous lesion. We will start with the macules, and everyone should know a very good example of each. So macules is flush with the adjacent mucosa. There is a noticeable changes in the color from the normal skin or mucosa, maybe due to an increased vascularization or inflammation, or maybe due to pigmentation such as melanin, hemostatin, or maybe foreign materials. A very good example of that in the oral cavity is the melanotic macule. Second, papule. Papule is a raised lesion above the skin or the mucosal surface. It is smaller than 1 centimeter in diameter. A very good example is the pseudomembranous candidiasis. Plaque is a raised lesion which is greater than 1 centimeter in diameter, and it is essentially large papules. Nodule is the protruded lesion above the skin or the mucosa, forming a characteristic dome-shaped structure. A very good example is the irritation fibroma. Vesicles, these are small blisters containing clear fluid which are less than 1 centimeter in diameter. Pulli, these are elevated blisters containing clear fluid which is greater than 1 centimeter in diameter. Erosion, these are red lesions resulted from rupture of vesicle or pulli, or maybe due to trauma, or maybe result from thinning or atrophy of the epithelium in case of inflammation. A very good example is in case of lichen planus. Pustule, these are blisters containing purulent material and appear as yellow. Ulcers, well circumscribed, sometimes depressed lesion with an epithelial defect, covered with fibrin clots. A very good example is the aphthous ulcer in the oral cavity. The last one is the purpura, which is a reddish to purple discoloration caused by leakage of blood from the blood vessels in the connective tissue. These lesions don't plunge when pressure is applied on it, and these are classified according to their size into petechiae, purpura, and ecchymosis. Vesicular, ulcerative, and bullous lesion may be classified according to the type of ulcer and chronicity into patient with acute multiple ulcer, patient with recurring oral ulcer, patient with chronic multiple ulcer, patient with single. We will start with patient with acute multiple ulcer. There is a list under this title. Include herpes simplex virus infection, varicella zoster virus, cytomegalovirus infection, coxsackie virus infection, necrotizing ulcerative gingivitis and necrotizing ulcerative periodontitis, erythema multiforme, Stevens-Johnson syndrome and toxic epidermal necrolysis, plasma cell stomatitis, and oral hypersensitivity. We will start with herpes simplex virus infection. In the primary infection, there is an initial contact with the virus and it acquired inoculation of the mucosa, skin, eye with infected secretion. The virus travel along the sensory nerve axon, established chronic latent infection in the sensory ganglia, mostly trigeminal ganglia. have extraneural latency. That's mean herpes simplex virus remaining latent in cell other than a neuron such as epithelium. This which they play an important role in recurrence herpes simplex virus infection, mostly for example in the lips. Recurrent herpes simplex virus infection result when herpes simplex virus reactivated at latent sites and travel centrally to the mucosa or the skin, where it is directly cytopathic to the epithelial cell, causing recrudescent herpes simplex virus infection in a form of localized vesicles or ulcer. The most common affected site, oral, genital, and herpes simplex virus infection in the cornea is a major cause of blindness in the world. Herpes simplex virus 1, type 1 and 2 cause herpes Whitler, which is infection as you see in the finger when there is a crack or there is wound in the finger come in contact with the virus, resulting with herpes Whitler. It was a common occupational hazard for the dentist previously, before the widespread of gloves. Other type of herpes simplex virus infection may include infection of the skin spread through the sport of wrestling, herpes encephalitis, esophagitis, pneumonia, and it is an important etiological agent in erythema multiforme. It has been found recently that 77% of patients with Bell's palsy were diagnosed with herpes simplex virus infection, and that supported by a better outcome when treating those patients with antiviral therapy. So herpes simplex virus infection involved in the pathogenesis of Bell's. Herpes simplex virus type 1 affecting children, teenager and young adult in the first contact in their life, called primary gingivostomatitis. There is 1 to 3 day viral prodrome of fever, loss of appetite, malaise, myalgia, which may be associated with headache and nausea. This will lead to poor oral intake, and patient may need to be hospitalized for hydration. Viral infection is a self-limiting, otherwise a normal patient, and resolve within 10 to 14 days for typical viral illness. Oral finding within a few days of the prodrome, there is an erythema, cluster of vesicles, and or ulcer appear on the keratinized mucosa, hard palate, attached gingiva, dorsum of the tongue, non-keratinized epithelia in the buccal, labial mucosa, ventral surface of the tongue, and soft palate. These vesicles break down rapidly, forming ulcer, usually 1 to 5 millimeter. These ulcers coalesce, forming larger ulcer with scalloped border. These border surrounded with marked erythema. The gingiva is often erythematous, and the mouth is extremely painful. There is a difficulty in eating and swallowing. Primary herpes virus infection in the adult may follow the same pattern. This is the picture of primary herpes gingivostomatitis. You can see the oral cavity, the lips, the tongue. The term recrudescent herpes simplex virus should be used to refer to the actual ulceration caused by reactivated virus. Fever, ultraviolet radiation, trauma, stress, and menstruation are important trigger for the reactivation of herpes simplex virus. The recrudescent herpes simplex virus on the lips is called recurrent herpes labialis and can be seen in 20 to 40% of young adults. These are associated with prodrome of itching, tingling, burning in approximately 50% of times, followed by the appearance of papule, vesicles, ulcer, crustation, and then resolution of the lesions. Pain can be seen in the first 2 days only. There is a suggestion that patients who don't experience prodrome phase in the epithelium area that will be affected by the virus are less responsive to topical therapy. So if there is no prodromal phase, there is less response to topical therapy. Recrudescent intraoral herpes simplex virus in immunocompetent host mostly occur in keratinized mucosa, including heart mucosa, attached mucosa, dorsum of the tongue. The same thing, 1 to 5 millimeter single or clustered painful ulcer with a bright erythematous margin. One common presentation of the pain in the gingiva 1 to 2 days after the scaling and prophylaxis or other dental treatment. Lesion may appear as 1 to 5 millimeter painful vesicle, but more often ulcer on the marginal gingiva. So if we can see marginal lesion in the gingiva, which is painful after scaling and polishing, this is what is called the recrudescent intraoral herpes simplex virus infection. Herpes simplex infection in immunocompromised patient. Immunocompromised patient, those who undergo chemotherapy, radiotherapy, or those who undergo organ transplantation. Also, patient with immune deficiency syndrome, AIDS, may occur in any site in the oral cavity, but may be several centimeters in diameter and may last for several weeks or months if undiagnosed or untreated. Single recurrent lesion, ulcer or lesion, clinically indistinguishable from recurrent aphthous ulcer if they occur on non-keratinized sites. These ulcers are painful, similar to those seen in immunocompetent patients, except they may be larger and often seen in non-keratinized site in the oral cavity. They may be depressed with a raised border, presence of 1 to 2 millimeter vesicle or satellite ulcer at the edges of the main ulcer is a helpful sign, which means that a vesicle rupture leaving an ulcer. So the margin will be irregular with a tags, tissue tags. This is a particular problem in patients undergoing hematopoietic stem cell transplantation when reactivation of herpes simplex virus in approximately 70%. Considering the laboratory diagnosis, cell culture is the gold standard test for diagnosis because the virus grow readily in tissue culture. Most recently used PCR using a swab and it is 3 to 4 times more better than the using the tissue culture. Real-time PCR also shown to be highly sensitive and specific. A primary herpes simplex infection associated with elevated immunoglobulin M IgM titer, which may occur within days, followed by several weeks later by permanent IgG titer that indicate a previous infection but confer no protection against reactivation. Herpes simplex virus lesion or infection are not generally biopsies because the clinical appearance and history are a characteristic. It means spot diagnosis. For example, infection is confirmed with a culture or cytology specimen when it is necessary. If we want to distinguish or differentiate between two types of virus or other type of lesion, we may do the culture or cytology, but biopsy is never ever. Management of herpes simplex, primary herpes simplex virus infection is mostly directed toward pain control, supportive care, and definitive treatment. In the past, healthy patients with primary herpetic gingival stomatitis treated only with hydration and supportive measure. Since a cyclovir family has been discovered and it is inexpensive, safe, and readily available, it is appropriate to treat patients with primary infection because it reduces viral shedding and inactivity. Acyclovir inhibits viral replication and is activated by the virally produced thymidine kinase. As such, it has little activity against non-virally infective cells. The use of acyclovir of 15 mg per kg body weight 5 times a day in children found to be reduces the duration of fever, virus shedding, stop progression of lesion, improve the oral intake, and reduce the incidence of hospitalization for children. And there is a new generation of the acyclovir family called Bullous, which is a prodrug of acyclovir, has 2 to 5 times the bioavailability of acyclovir. Together with valcyclovir is now widely used. Recrudescent herpes simplex virus infection. For example, recurrent herpes labialis can often suppressed by reducing tissue damage, such as using sunscreen, although it is self-limiting, and we can use topical antiviral medication to reduce the shedding, inactivity, pain, and the size and the duration of lesion. Topical antiviral medication such as 5% acyclovir cream, 1% benzyclovir cream, and 10% tocosanol cream are effective to be used 5 to 8 times a day at the first prodrome or sign of the lesion. Systemic therapy with valcyclovir 2 gram every 12 hours for 1 day, or valcyclovir 1500 milligram single dose, or both effective in treating active lesion in recurrent herpes labialis. For intraoral lesion, treatment is with 500 to 1000 milligram valcyclovir 3 times a day, or 400 to 800 milligram of acyclovir for 7 to 10 days. Suppression of the herpes simplex virus infection in patients who develop large lesion, frequent episode, erythema multiforme is effective with variable doses of acyclovir, valacyclovir, and valacyclovir. These regimen called suppressive regimen and can be used for patients susceptible to recrudescent herpes simplex virus infection after dental procedure. Now we're going to talk about the herpes simplex virus in immunocompromised patient. Is there any difference between this infection and immunocompetent patient? Herpes simplex virus infection should be treated with a systemic antiviral to prevent dissemination to other sites, such as esophagitis, or systemically. The primary pathogen for herpes encephalitis, herpes pneumonitis, is type 1 for patient undergoing hematopoietic stem cell transplantation. Antiviral therapy such as acyclovir or valacyclovir at a suppressive dose should be initiated for all patients who are herpes simplex virus seropositive. So acyclovir 400 mg 3 times a day or 500 mg valacyclovir twice a day should be used as suppressive doses for such type of patient. Acyclovir resistant herpes simplex virus is most frequently seen in this group of patients where they are virally derived thymidine kinase that activate acyclovir is mutated. In such cases, another type of cyclovir will be used. The dosage of acyclovir family of a drug should be adjusted for both age of patient and renal health. So patient should be asked about any problem in his renal system. If there are any problem in the renal system, we should adjust the dose. A number of vaccine nowadays and therapy against the herpes simplex virus are currently under development. Now we will talk about another type of virus, which is the varicella zoster virus infection, which is called chickenpox. The virus also become latent in the dorsal root ganglia or ganglia of the cranial nerve. Reactivation produce herpes simplex infection, herpes zoster infection, commonly called shingle. The incidence of herpes zoster infection increases with age and the degree of immunosuppression. This increases to 10 per 1,000 in those older than 75 years of age. However, it is not uncommon to see herpes zoster infection in the elderly, patient undergoing cancer therapy, patients on chronic immunosuppressive medication or drug therapy, and those with AIDS. Also, similar to herpes simplex virus, this virus is cytopathic to epithelial cell of the skin and mucosa, causing blister and ulcers. Transmission is usually by the respiratory route with an incubation period of 2 to 3 weeks. We have what is called the post-herpetic neuralgia, which is a morbid sequelae of the herpes zoster infection, is a neuropathy resulting from the peripheral and central nervous system injury and alter central nervous system processing injury. And what is the clinical finding of varicella zoster infection? It is mostly occur within the first 2 decades of life, associated with low-grade fever, malaise, development of intensely pruritic maculopapular rash, followed by vesicle that have been described as deuterop-like. These vesicles turn cloudy and pustulated, burst, and scupped, with the crusts falling off after 1 to 2 weeks. The lesion mostly affect face, trunk, and spread centrifugally. Central nervous system involvement associated with cerebral ataxia and encephalitis. Other complications of this varicella virus, including pneumonia, myocarditis, and maybe hepatitis. Immunocompromised hosts usually experience more severe disease, more blister, a prolonged course involving of the lung, central nervous system. This is significantly higher mortality rate. These things associated with the virus lead to higher mortality rate. Also, secondary bacterial infection by a gram-positive cocci may have severe septic sequences in compromised patient. Herpes zoster infection in the skin called shingle. Healing may be within 2 to 4 weeks with the scarring and hypopigmentation. They found that 20% of patients with Bell's palsy associated with varicella zoster virus. A serious and occasional side effect of herpes zoster is acute retinal necrosis. One of the most important complications of the herpes zoster infection is the post-herpetic neuralgia, which may be defined as a pain that remains for 120 days after the onset of acute rash of the pain. Patient older than 50 may develop post-herpetic neuralgia in up to 70%. In another word, 70% of older patients more than 50 can develop post-herpetic neuralgia, and 50% of them have a debilitating pain, which is usually sharp, stopping, burning, and may last for 1 month, or sometimes unfortunate patient may experience pain for years. Predisposing factor for this type of infection: older age, prodromal pain, and more severe clinical course during the acute rash phase. Immunocompromised patients often experience more severe varicella zoster infection, which may appear as atypical bilateral and may involve multiple dermatomes, while the actual type of varicella zoster is unilateral, affect the unilateral sides. On rare occasion, herpes zoster infection may involve just one dorsal root ganglion, but also anterior horn cell, which may lead to so as any clinical course of virus, it takes 10 to 14 days, and post-herpetic neuralgia in the oral cavity is uncommon. Laboratory finding is the same as herpes simplex virus. Oral swab for viral isolation using tissue culture, still the best way to confirm the diagnosis. Also, they can use direct fluorescent antibody testing using a smear. Also using PCR, real-time PCR to detect viral antigen which is expensive but highly sensitive. In herpes simplex, in herpes zoster infection, there is an inflammation of peripheral nerve leading to demyelination and Wallerian degeneration, as well as degeneration of the dorsal horn cell of the spine. Management of herpes zoster infection, similar to herpes virus infection, directed towards pain controlling to prevent postherpetic neuralgia, supportive care, hydration, and the definitive treatment to minimize the risk of dissemination, particularly in immunocompromised patients. Now, I want to concentrate on a very important thing here in using the medication. Using aspirin, especially in children with varicella zoster virus infection or influenza, may be associated with a syndrome which is called Reye syndrome. This syndrome is potentially fatal for children, and aspirin is contraindicated in such case. This syndrome characterized by fatty liver degeneration and encephalopathy. So, the preferred analgesia for children in influenza, in case of influenza or herpes zoster virus, is the ibuprofen type of analgesia, which so to be away from the Reye syndrome. Treatment of patient with herpes, primary herpes zoster infection include the use of acyclovir 800 milligram 5 times a day to reduce the to reduce the severity of the lesion, hospitalization, other complication also. However, acyclovir has a poor bioavailability comparing with other antiviral medication. So, valacyclovir 1000 milligram 3 times a day, or one acyclovir 500 milligrams 3 times a day for 7 days is effective in treating herpes zoster infection and should be started within the first 72 hours of the disease onset. Okay, it should be started within the first 3 days. These drugs also used in the incidence of postherpetic neuralgia compared with acyclovir. This medication used to reduce the incidence of postherpetic neuralgia compared with acyclovir. Now, we said that the most important sequelae of the herpes zoster infection is the postherpetic neuralgia. So, how we can treat the postherpetic neuralgia? There is two lines of treatment. The first line using gabapentin, and the secondly 5% lidocaine patch and 0.025% to 0.8% topical capsaicin. The second line of treatment is the opioid analgesia, tricyclic antidepressant. There is approach of using corticosteroid together with antiviral therapy as an attempt to reduce the postherpetic neuralgia has not been proved effectiveness, although many researchers have been used. However, early treatment with valcyclovir or valcyclovir may prevent it. Okay? Other modality of treating a patient with post-herpetic neuralgia as a case report cases suggests that using botulinum toxin may provide relief and attenuated vaccine for preventing varicella-zoster viral virus infection has been found to reduce the incidence of outbreak. Vaccination of older adults with this vaccine may have a benefit of increase the antibody titer, boost cell-specific immunity, and reduce the incidence and or the severity of the subsequent herpes zoster infection and post-herpetic neuralgia.